Hi everyone, I'm Dr. Preeti and I'll be taking you through the RRR series of MRCOG Part 2, a subfertility topic. So let me take you through some important concept-based questions. Starting with a small quote, stay focused and never give up. So this patient is a 31-year-old lady suffering from primary infertility of 22 years duration. She was on OC pills for 7 years because of irregular menses. Still, her menses are irregular. She has stopped using OC pills from the last 2 years. Her BMI is 38. Her baseline FSH level is 5.2. LH is 8.3. Estradiol is 153. Ultrasound shows polycystic ovaries, and HSG shows the bilateral patent tubes. Her partner's semen analysis is normal. So the lead statement says, what is the most appropriate treatment option for this case? So as you can see, she's an irregular menses patient. So most likely it's a case of anovulation. But at the same time, she has a very high BMI. Even if she conceives with such a high BMI, first of all, the ovulation induction drugs will never be much helpful to her. In case if she conceives also, she'll be having a really great trouble carrying the pregnancy forward, or she might develop really high complications in pregnancy. So the most appropriate treatment for this patient right now is basically weight loss. Second patient is a 28-year-old PCOS, primary infertility 4 years, extends the fertility clinic. Her cycles are very irregular, currently on metformin. Which is helping her control her weight also, but she's still not having a regular menses. She's very keen to commence the fertility treatment, and hysterosalpingography confirmed the patent tubes. Again, the most appropriate treatment option. The weight is still now under control. She is having BMI of 30 and less than 30. So it is less than 30 is okay. But because the cycles are irregular and she's a case of PCOS, she now requires an ovulation induction with the clomiphene citrate as a first line of management. 30-year-old primary infertility PCOS diagnosed 3 years ago. She has a BMI of 25, keen to try ovulation induction, which she has failed to ovulate after 5 cycles of the clomiphene citrate, and she has a persistently high LH level. So according to the NICE guideline, if clomiphene citrate treatment fails for the patient, usually they will give a stepwise management. That is, clomiphene fails at a low dose, they will increase the clomiphene dose. Or if the clomiphene fails as a single thing, then they might add clomiphene with metformin. Already 5 cycles she has gone with. And when they have mentioned that there is a persistent hypersecretion of LH, now nothing else apart from laparoscopic ovarian drilling can help her, because drilling the ovary will reduce the amount of ovarian androgen production producing tissue, resulting in the fall of reduction in LH and normalizing the hyperandrogenemia, which is the reason for anovulation. So this patient is a best candidate for laparoscopic ovarian drilling. BMI, a woman of BMI 28, PCOS, ovulation induction was done with clomiphene and metformin but could not succeed. She now returns to the clinic and wants to know her management. What is the most appropriate management in her case? Now, because this patient is somebody who is failed with clomiphene and metformin also, now we have two options, either laparoscopic ovarian drilling or we can try with the gonadotropins. Look, laparoscopic ovarian drilling is a surgical method. Whenever it is done, it will cause harm to the ovary. But there are certain indications where LOD is preferred over gonadotropins, like hypersecretion of LH, like if she has a period pain, menstrual pain, where you suspect she is also having endometriosis and you need to treat. Not only diagnostically you will do, but also you will treat the endometriosis, LOD, ovarian bleeding, and you will also check the tubal patency. Or she has a high risk factor where the you think that the tubes might be affected. So in that case, laparoscopic ovarian drilling will solve two purposes. Check the tubes, and laparoscopic ovarian drilling can also be done. Or she is a condition patient who tells you that I can't come to the clinic again and again for USG monitoring. So rather than giving gonadotropins, in that case, LOD is preferred. Okay. But here the patient has no such complaints. So gonadotropins will be preferred because LOD has a high risk factors. It is a surgical procedure and causes damage to the ovaries as well. Now, Coming to the next set of questions, where the first patient is a 20 years old lady, primary infertility, trying to conceive for 24 months. She is found to have everything normal with respect to diagnostic laparoscopy, and husband semen analysis is also normal. What is the appropriate management plan for her? Because she has been trying for 2 years and everything seems to be normal. So now it's a case of unexplained infertility, and after 2 years, she requires a IVF management. So we will refer her for IVF. Second question is a patient of primary infertility, 3 years duration, high AFC count, high AMH. Her first IVF has been planned, but ovulation stimulation protocol, what is best suited for her? So this patient, whenever there is a patient who is a high responder, for example, who has a high AFC count, high AMH count, these patients, when you do the ovarian stimulation, they are at very high risk of OHSS. So whenever there is a high responder, it is always good to have a GnRH antagonistic protocol, okay, for down regulation. And because she is a high responder, so FSH will be used with a minimal dose. So she will require a GnRH antagonist protocol with a minimal FSH stimulation. Last patient is trying to conceive for the past 3 years. Her tubes are normal. She has oligomenorrhea and semen analysis is also normal. But her FSH-LH seems to be very, very low. She is not ovulating. That is why her day 21 progesterone is very less. FSH-LH is very low. Thyroid normal, prolactin levels normal. When FSH and LH are very, very low, that means it's a case of hypogonadotropic hypogonadism. These patients will be best managed by pulsatile GnRH, the round the clock what the pulsatile GnRH does in our normally in our body. Here the function of the purpose of giving the pulsatile GnRH will be the same. Okay, so the best answer for this patient is pulsatile GnRH agonist. So you should know the values, who are the low response patients, who are the high response patients. Okay. So sometimes not only AMH is given in picomole, but it is also given in nanogram per ml. So you can see it is 5 nanogram per ml. So she is a case of high responder. More than equal to 3.4 is a high response. And how do they are managed according to the normal responders, poor responders, and high responders? This is a general template from the ESHRE. So I think this will be helpful for you for any other question which comes related to this. Okay, now there is a 32-year-old man who presents to the fertility clinic with 30-year-old female partner. Um, they have been trying to conceive from last 15 months. They are reasonably fit and well. No severe medical history of note. Semen analysis reports are given. Female has good ovarian reserve. HSG is normal. What course of action? Single most appropriate answer. What course of action you recommend to them? Now looking at the patient semen analysis, it is seen that the counts are low, the motility is low, and on appearance they are normal, but morphologically also they are low. Okay, so basically it is a case of oligoasthenoteratozoospermia. Okay, now first diagnosis of oligoasthenoteratozoospermia requires a, because it's not severe variety, so this requires a repeat analysis in 3 months, but at the same time you will give them lifestyle modification advice. Same couple has come after 2 years of trying. The course of action you recommend to them, the repeat semen analysis results were as follows. So now it has been 2 years now. After 3 months, they have done the semen analysis. Might be they couldn't come back. So it seems to be not much good. It's almost the same. If you see, the progressive motility was 21. Now it is reduced to 10%. Morphology was 3%, it is now 2%, and sperm volume concentration was 12.4, it's 10.1 now. So because the condition has not improved, rather it is a little serious condition with the severe defects. These patients, if you wait more, there will be no benefit for these patients. And severe variety of defect when the female count has, the best option for these patient is ICSI. Okay, so this is the patient where you can offer them ICSI management. I guess the ICSI is missing in the options, but yes, ICSI is the best option for these patient. Okay. Now, moving on to a 24-year-old lady attends the clinic after 26 months of trying to conceive, does not have any medical history. She has been ovulating. Her progesterone levels 2 times is 33 to 36, more than 30 is ovulation. Partner 36 years old, healthy but smoker, drinks alcohol. History of mumps when he was 16 years old. The semen analysis shows absence of sperms. LH, FSH levels are raised. Testosterone is very low, is low, and normal karyotype, does not have Y chromosome deletions. What will be the most appropriate management option for these? Again, this patient is actually a case of primary ovarian failure. So whatever you do, you actually will be not helping the patient much. So in this case, sperms are not there, so better is to go for the donor sperms. Okay, now it is a choice. The patient, because patient is well, she does not have any issues, she has regular cycles and patency of tubes, so either donor IUI can be done, which can be the option, which is a better option, and uh, easily, because it's a easy option, cost effective also. So you can give her the option of donor insemination, which is the best thing which you can offer them. Okay. Okay. uh 29-year-old woman with a history of 3 years of infertility, 3 days following an oocyte retrieval. She complains of abdominal pain, vomiting, tense ascites, shortness of breath, oliguria, hematocrit 46. Severe OHSS diagnosis was made. She was treated with fluid replacement, but hematocrit became normal, but she's still oliguric. So for the OHSS patient, if the patient has severe OHSS and oliguric, fluid replacement is not helping her, the next step in management is paracentesis. Okay, and even if that is not helping her, then the next step of management for this patient is giving a diuretic shot. The most common sexual disorder in a female is, so most commonly it is loss or lack of interest in sex. Okay, this is one of the exam tested question, important, good one. A patient comes to you with a 4 recurrent first trimester miscarriage with a new partner. She has a one living normal child from a previous partner. Her EPLA screening is normal, pelvic ultrasound is normal. What is the next step in investigations? Now, ideally, she should have got the karyotyping of the products of conception done when she got miscarriage. But now, if it is not available, it is better to get the karyotyping of the partner done. Okay, so cytogenetic analysis, uh, testing of pregnancy tissue is unsuccessful or there is no pregnancy tissue available, then parental karyotyping should be offered. A woman with the RPL, third consecutive miscarriage, comes 4 weeks after miscarriage for the laboratory testing of EPLA. When can you schedule the EPLA test in this case? Ideally, after any miscarriage, it has to be 6 weeks after miscarriage. You need to do the EPLA test. So 4 weeks already she has elapsed. So now after 2 weeks, you will call her. So total of 6 weeks, she can come for the EPLA screening. A woman attends the miscarriage clinic for having experienced her third consecutive first trimester loss. What are the investigations that are taken? Please remember, EPLA, pelvic ultrasound, and cytogenetic analysis of the products of conception. These are the 3 very important tests which needs to be done. Whenever a patient with the recurrent miscarriage comes to you, EPLA, TSH and TPO antibodies, 3D ultrasound, uh, genetic analysis of products of conception, parental karyotyping, as I have already told you, and male is assessed for the lifestyle factors. Sperm DNA fragmentation in couples with RPL can be considered based on indirect evidence. A couple with infertility, female results are normal, regular cycle, ovulating with a patent tube, husband has small penis and small testes. Semen analysis shows azoospermia, which is confirmed by repeat test. What will be the likely cause? So the Kalman syndrome will have anosmia as a feature which should be mentioned uh, for the patient with the low FSH LH and having azoospermia. Kalman syndrome may have little variation in the penis and testis, which may be smaller, but not as much as which is seen in Prader-Willi syndrome. Fragile X syndrome has macro orchidism, that is big testis, and Cushing is not related to these things. So for Kalman, anosmia should be there. Prader-Willi is actually a triad where hyperphagia, obesity, mental and behavioral problems, along with the sexual problems like small penis and testes and azoospermia is seen. Cushing will not have genital atrophy, dystrophy any type, and Fragile X syndrome has large testes. A 34-year-old lady, Paris woman, was diagnosed with stage 3 endometriosis. She was on GnRH analog for 1 year. Subsequently, she had laparoscopic excision of endometriosis. She's in pain, still in pain. What is the next step in management? So, any patient with a deep-seated endometriosis who has already received any medical or surgical management and is not responding to them, the best treatment for these patients is aromatase inhibitors. Okay, so this is a general template of the endometriosis, which you should know. A 24-year-old Asian woman attends the clinic with a history of failure to conceive after 12 months of unprotected intercourse. She does not have any medical and surgical history of note. Her menses are regular. Partner is fit and well. What investigations will you offer her? They have already tried for 1 year. 1 year, we give them a chance to try normally, even without investigations. Now, even after 1 year, they are not trying. So, what investigation you need to do? You need to check female for ovulation and tubal patency, and you need to check male for the semen analysis. So, semen analysis, progesterone, and HSG will be done. She does not carry any high risk factors. So, laparoscopy and dye test should never be the first choice. A woman underwent IVF is now 12 weeks pregnant. For the serum biochemical screening for aneuploidies, which of these could result in a false testing? So, they say that PEPA A is low in pregnancies that are conceived by ART, and they may actually, the levels may be decreased and not give the correct screening for the aneuploidies in the pregnancies which are conceived by IVF. A woman who wishes to start fertility treatment informed that her husband just came from Mexico, because these are Zika prone areas. So you should, whenever a partner or both the partners have traveled, they should always plan a little gap for not planning pregnancy once they return from the Zika prone area. So if only male has traveled, so they should avoid getting pregnant for the next 3 months. Okay. So did male partner travel? Yes. So avoid pregnancy for next 3 months. Okay. Female didn't travel, but the male traveled. So avoid for next 3 months. If female traveler was there, yes, and male was not traveling, then you have to avoid pregnancy for the next 2 months. So this was all from my side. I hope this question answer session of RRR series of subfertility helps you. All the best for your exam, and thank you so much.